Hi, I'm Toby Campbell, an oncologist and communications researcher at the University of Wisconsin. I'm here to teach you how to use TrialTALK, a designed conversation to help oncologists discuss treatment decisions, including clinical trials, with patients and their support network. Our research shows that TrialTALK improves shared decision-making and clinical trial participation. TrialTALK incorporates and organizes all the information an oncologist typically uses when conducting a shared decision-making conversation about cancer treatment options. The diagnosis and its prognostic implications, the available treatment options, the treatment impacts like the time commitment involved and potential side effects, metrics to discuss the effectiveness of the options like response rates or overall survival, eliciting values and goals, making a recommendation. Let's start with your patient, Mr. Alodin. He is your 64-year-old biology teacher with metastatic pancreatic adenocarcinoma who had scans today and has progressive disease. After discussing his scan results, you plan to use the TrialTALK tool to discuss his treatment options and help him make a decision. When you're done, you will have discussed the current diagnosis, its prognostic implications, the available treatment options, the efficacy of each of these options, and their impact and side effects. We start with the preparatory phase before you even see the patient in your office or workroom. You review the scan results and realize it's progressive disease and you need to change therapy. As you gather the information, you need to ask yourself, what are my patient's next treatment options? How well does the standard of care therapy work? Are there any clinical trials available? What's the rationale for the trial? Efficacy? Toxicity? Or something else? Confident you have the information you need, take a breath and meet with your patient. We open the conversation with an invitation to discuss the new information. For Mr. Alodin, this is the progressive disease seen in the liver on today's CT scan. First, we have to clearly state that this is bad news.
Should we talk about your scans? It's unfortunately bad news. The CT scans show some new cancer in your liver today.
Next, allow time for the patient to process the news and respond to their emotions. Ask them,
Would you like to talk about what this means?
Well, yeah, sure.
This means that the current treatment isn't working any longer, and we have to think about what to do next.
respond to their emotion.
I wish I had different news. How are you feeling about this?
Now that you've set the stage, discussed the news, and allowed them time to react and respond, you can assess if they are ready to transition to talking about treatment options. As you're transitioning through different parts of the conversation, it's helpful to give the patient some control over the flow of information. It's easiest to do this with questions. You might say something like,
Are you ready to talk about our treatment options?
let's turn our attention back to the TrialTALK diagram. Let's review the TrialTALK pen and paper diagram. It's drawn by you before or during the visit using a blank piece of paper and your knowledge about your patient and his treatment options. The diagram is laid out so it unfolds naturally as the conversation moves along. It has the following core elements: the diagnosis and prognostic implications, treatment options, the type of treatment, the impact of the treatment, and efficacy measures for comparison. The diagram is intended for patients and families to take home. This allows you to reach out into those conversations happening after they have left your visit and to be present to ensure the options they are considering are accurate and based on the information and treatment details you think are most important. The first option to discuss, not using anti-cancer therapy, gives the patient perspective on what might happen if we used supportive care alone. While this may not be their ultimate decision, by placing this option first in the discussion, You help them develop prognostic awareness, that is, an awareness of the seriousness of their disease. It also sets the stage to help you explain the rationale behind the standard cancer treatment. We hear from oncologists that it can be hard to discuss best supportive care alone first. In truth, anytime you're helping your patient develop prognostic awareness, you're having a life-altering conversation. Simply by discussing this option first, you help patients better understand their disease and their prognosis. The effort you both put in now to come to terms with what it means to have this disease pays dividends both now and in the future. It also means, by doing the hardest work up front, the conversation will get easier for both you and the patient as it moves forward. We know the majority of cancer patients misunderstand their prognosis and the goals of therapy, even though oncologists routinely disclose that information. Part of this disconnect for patients is where the oncologists place that information in the conversation. Simply by discussing this option first, you help patients better understand their disease and their prognosis. The three options you ultimately have to discuss are no anti-cancer therapy, or best supportive care alone, standard of care cancer therapy, a clinical trial. For each option, you will discuss the same information: what it's called, for example, a drug name, its impact on their life and toxicity, its efficacy relative to the other options. Discuss impact on life. In this section, consider how the patient will spend their time. Do they need scans, labs, infusions, clinic visits? Also consider toxicity and how that might impact their preferred activities. You could tell Mr. Olodin,
No further anti-cancer therapy means you'll mostly be spending time at home. You won't need labs, infusions, or imaging, and you'll be coming to the clinic less. I won't get in the way of you spending time in your garden.
Finally, for each option, you discuss efficacy. It's important to consider ahead of time how you will measure effectiveness across all three options. This section gives the patient the ability to compare the options using the same benchmark. It also creates the opportunity for you to introduce and explain the rationale for the clinical trial option. You can use any measure, or more than one, which is relevant to the decision at hand. For example, some common measures are response rates, 1-year survival, or toxicity. For Mr. Olodin, you could use 2, disease control rate and overall survival.
So with supportive care alone, we won't be able to control the cancer, unfortunately. And in patients like you with metastatic pancreas cancer, I would expect the cancer to be controlled in 0 out of 10 patients. And typically we're talking about a time frame of a short period of months.
Let's shift our attention to the next option, standard of care therapy. Remember, for each option we name the treatment, discuss the impact, and indicate its effectiveness. First, name the treatment: chemotherapy, bone marrow transplant, etc. Next, provide the details and impact on life: IV versus oral therapy, how often medication would be administered, whether the regimen is intense, how much in-hospital time. This is also a good time to discuss whether the patient would be able to continue the meaningful activities they mentioned before. In the preparatory phase for Mr. Olodin, we selected gemcitabine and Abraxane as second line, and we refreshed our memory that it has a 50% disease control rate and a 6-month median survival in this setting. To Mr. Olodin, we might say,
The standard of care chemotherapy is with 2 IV chemotherapy drugs called gemcitabine and Abraxane.
We would then describe the treatment schedule of this 28-day regimen and remind him of the impact.
So this is moderately intense chemotherapy. You would be here once weekly for 3 weeks in a row and 1 week off. On your non-treatment days, I would expect you to experience some level of fatigue, but I would expect that you'd be able to do some of your daily activities.
You go on to describe some of the common side effects. Next, discuss efficacy.
So if I took 10 people like you with metastatic pancreas cancer, I would expect this chemotherapy to work in only 5 out of 10 of those patients. If we look forward from now, I would expect that this chemotherapy would work on average for a period of 6 months. For some patients, it won't work at all, and for some patients, it will work for a short number of years.
After discussing efficacy of standard of care, allow time for the patient to respond. They often state they wish there was something better. This is where TrialTALK helps you create a common understanding for the rationale for the clinical trial. You can easily align with their hopes for better treatment and then introduce the trial.
I wish the options were better too. We're always trying to improve upon our treatment options, and we do that through research in a clinical trial to try to improve upon our standard of care chemotherapy.
In this way, TrialTALK helps the patient understand the context for a clinical trial for them. We are now ready to talk about the clinical trial and follow our process of naming it, describing the impact and its efficacy. Name the clinical trial agent. Next, provide details and impact on life. Consider the impact on their time for eligibility, travel, and treatment, side effects, the benefit of clinical trial staff being involved. Acknowledge the uncertainty and also any optimism you have about the new therapy. Experienced users of the tool will discover the patient naturally prompts the clinician through the conversation. Ask your patient.
How are you thinking about this?
Finally, based on your conversation and the patient's values and goals, make a recommendation. Your recommendation might be one of the options, or it could be to give them time to consider them further. Let's summarize. TrialTALK has the following steps. Set the stage by discussing the diagnosis, test results, and any prognostic implications. Say you have options. No further anti-cancer therapy, standard of care, clinical trial. Describe each of them using the same types of information, name, impact, and efficacy. Make a recommendation. Encourage deliberation with your patients and ask them,
How are you thinking about this?
Many people may hear this and think, I already do that. I challenge you to go and try the 5 major steps I've outlined today in TrialTALK. Our research results are clear. TrialTALK effectively improves patient comprehension, goal-concordant decision-making, and clinical trial participation. Thank you for watching our presentation. With a few tries, I'm confident you will find this designed conversation a helpful addition to your practice.